Welcome, everyone, to our Between Us series tonight. My name is Stephanie Jonah, and I'm a development officer at Signature Events at the Royal Alexandra Hospital Foundation. I have the privilege of being here this evening alongside the incredible Lois Hole Hospital Women's Society, united in our mission to raise funds for the Lois Hole Hospital for Women. We'd like to welcome to our Between Us series tonight an engaging evening planned with discussion from Dr. Colleen Norris on women's heart health. Before we begin, I'm also going to share my screen with you just to share in another exciting upcoming event that we are doing in honor of women's health. Um, so this is an incredible event that you won't want to miss that's coming up very soon. It's called Luminaries, and it is the inaugural first event of its kind in Alberta, hosted by the Alberta Women's Health Foundation, and it's quickly approaching on March 7th. If you'd like to scan the QR code to find out more, now is a great time. We'll also return the slide later in the evening if you missed it or didn't get a chance to scan it earlier in the podcast. It'll be featuring our presenter from this evening, Dr. Colleen Norris, as one of the speakers as well. Whether you're passionate about health, innovation, or simply want to be part of a community driving meaningful change, this event is your chance to make a difference. Plus, you'll leave feeling empowered and connected with like-minded individuals who'll also be in attendance. You can scan the QR code or visit the website you see here. Mark your calendar, bring a friend, and join us for an unforgettable afternoon. And hopefully it'll be a great time during this Luminaries Luncheon event. And for now, you can join us for an unforgettable evening. Let's illuminate the future of women's health together. And now I'm pleased to welcome Becky McIntyre to share a special message with us.
Amazing. Thanks, Steph. Welcome to Between Us, everyone. I'm Becky McIntyre, and my pronouns are she, her. I'm a volunteer and supporter of the Lois Hole Hospital Women's Society, and I'm excited to be here to represent the Women's Society on behalf of the co-chairs. Since our founding in 2017, we've raised over 1 million to support the Lois Hole Hospital for Women. Thanks to supporters like you, thanks to supporters like the people in the room with me right now. And also, I just want to shout out that we have over 300 people already online for this Between Us today, so that's amazing. We're thrilled to have you here as we work to raise awareness and funds for Alberta's only dedicated women's hospital, which provides specialized care for women in all ages and stages of life. Our Between Us series was created to provide a safe space for discussing intimate and often overlooked subjects in women's health, such as personal health matters. Thank you for participating respectfully with each other, using the Q&A and the chat box to ask your questions and be part of this great evening. And of course, a huge heartfelt thank you to Alberta Blue Cross for their generous support as our presenting sponsor. Your commitment allows us to host this informative series and make a meaningful impact in the community. So just before we dive into the session tonight, let me share a few housekeeping tips. Please type your questions into the for our speaker, into the Q&A box, and they will be addressed during the question and answer period anonymously. And know that anything you post in the chat box, though, is public, so all attendees can read it. Please also know that the speaker, Colleen Norris, is not able to provide personal medical advice, so it's something to keep in mind as you pose your questions. And we are using Zoom webinar, so only the panelists are visible. You don't have to worry about accidentally turning on your mic or your camera. That function won't work. But also, if LiveScript would help you in participating and enjoying this session tonight, you can turn that on your computer to help with your experience. And also know that each lecture is recorded and available on the Women's Society YouTube channel, and it will be posted there in the coming days. After the event, keep a watch for a survey to come out. You'll get a chance to provide feedback to us, but then also the chance to win a $25 gift card courtesy of Alberta Blue Cross. So thank you, and I hope you find tonight's session valuable. And I want to pass it over to our presenting sponsor, Alberta Blue Cross, and my friend, Marianne.
Awesome, thank you. So I'm Marianne Hart. I'm from Alberta Blue Cross. And my pronouns are she, her, and it's a real pleasure to be here tonight. With February being Heart Month, we are very much looking forward to hearing from Dr. Colleen Norris this evening on the importance of raising awareness about cardiovascular health. And we're pleased to be able to support the delivery of women's health information far and wide, and to be able to support one of the very few dedicated women's hospitals across Canada, the Lois Hole Hospital for Women. As always, we're very proud to be sponsoring this series. We're so grateful that you have all tuned in to spend your evening with us. Thanks.
Tansei, greetings. We gather here in Treaty 6 territory, where the Blackfoot, the Cree, the Dene, the Nakota Sioux, the Anishinaabe, Saulteaux, the Métis, and the Iroquois peoples, which is my family, call this our homelands. During my grandparents' lifetimes, this land was not only their home, but their hospital and their healthcare system. Their health and well-being were connected to each other and to the land. The berries we picked, our medicines, sweetgrass, sage, bare root, and many others were all harvested in the rhythm of the seasons. The water they would drink was from the lakes and the rivers, where they would also fish to feed our families. We must not forget how important our connection to the land is. For the food we grow, the water we drink, not just for ourselves, but for future generations. I'm here to remind you, we still have much work to do in our relationship with the land, the water, and each other. As Treaty 6 relatives, we must remember what our ancestors agreed to. As long as the sun shines, the grass grows, and the rivers flow, we will look after each other, the land, the water, and all the beings that we share these lands with. Hi, hi.
Amazing. Thank you, Marianne. Thank you, Alberta Blue Cross. It is now my honor to introduce tonight's speaker, and that is Dr. Colleen Norris. She's a professor at the Faculty of Nursing at the U of A registered nurse, holds the Kaverzin Chair in Women's Health Research for the Alberta Women's Health Foundation, and she's a well-respected expert in cardiovascular health. Additionally, Dr. Norris is a leading part of the Women's Heart Health Research Collaborative, which partners with CK Huey Heart Center, the Lois Hole Hospital for Women, and the Alberta Women's Health Foundation to improve women's cardiovascular care. Dr. Norris now focuses on how sex, gender, and hormones impact women's health throughout their entire life cycle, from perimenopause to postmenopause. Her research explores how these factors influence conditions like cardiovascular disease and other health concerns. And Dr. Norris's groundbreaking work continues to shine a spotlight on the complexities of women's health and aims to create a more holistic and inclusive to clinical practice and policy. So thank you so much for being here, Dr. Norris. So excited to see you again. And I'm going to pass it over to you for tonight's presentation.
Okay, so thank you for asking me to be here tonight. It's such a treat to come back and focus on women's heart, especially during Women's Heart Month. And it's a big month for us, the people, those of us that are working in this area. And so I'm so appreciative of the Between Us group for organizing me to have a forum to speak at. This is a picture of a medicine wheel that was taken from the Indigenous Corporate Training website. Medicine wheels represent the alignment and continuous interaction of physical, emotional, mental, and spiritual realities. And on the website, they write that they have identified 46 medicine wheels like this one in Alberta. And it constitutes about 66% of all the known medicine wheels. Alberta, it seems, is a core area for medicine wheels. Specifically, I would like to reflect on Indigenous medicine women who've lived and continue to live on the lands across Alberta, and the vital role that they play in their communities, often serving as healers, herbalists, and spiritual guides. We have much to learn from them. They utilize traditional knowledge passed down through generations to treat various ailments with natural remedies, including plants, roots, and other natural substances. Their practices were and are deeply connected to the cultural and spiritual belief of their communities, emphasizing a holistic approach that consider the physical, emotional, and spiritual well-being of individuals. And I think that sort of reflects on what the Between Us seminars are all about. So my first point, and if you've ever heard me talk, I say this every time, but I don't think we can say it enough, is that I would like to make the point that females and women are not small men. And not recognizing this has exacerbated health disparities and inequities, and I would say especially in women. This is a picture of the Vitruvian Man, meticulously created by Leonardo da Vinci, and it combines the principles of humanism, geometry, anatomy, and art. The circle and square were long thought out of as symbols of the divine and the earthly, respectively. By studying the proportions of the, quote, ideal human body, Leonardo and his contemporaries imagined that they could infer the rules guiding the universe. One of the most common uses of the Vitruvian Man today is an image associated with health and fitness and with the practice of medicine. And the idea that male and female bodies are the same is actually embedded in the arts, the sciences, and in modern day medicine. So when we talk sex and gender science, what are we actually talking about? Well, one of the phrases you might have heard is that every cell is sexed. And this may be a review, but it bears repeating. Every human cell in your body, and I'm going to repeat that, every human cell has 46 chromosomes. The 23rd pair of chromosomes is called the sex chromosomes, and those chromosomes are called either X or Y. Males have one X chromosome and one Y, and females have two X chromosomes. The fact is that females have two chromosomes in each cell, and as girls are growing, they have a special mechanism that randomly turns off one of their two X chromosomes. When one X chromosome turns off, the other is still working, and its genes are expressed, which means those traits show up in a female's body. And since not every cell turns off the same X chromosome, the cells express these differently from each other. And this is actually called cellular mosaicism, which not only means that females are more diverse than males, but it also means that there's incredible diversity amongst females. So when we talk about sex, I am actually talking about the defined biological construct that we think of as female or male. It encompasses hormones, genes, anatomy, and physiology. The important point here is that sex affects our propensity for trajectories, prevalence, treatment of health conditions, and diseases. There are differences between the male and female body in drug absorption, body composition, metabolism, diseases, and conditions that are due to sex. We also have discovered that many drugs on the market today, including the evidence-based ones we use for heart disease, were developed and tested on a sample of patients where on average 80% male. And based on our sex hormones, we have different drug absorption and different body composition and metabolism. So to be frank, aside from bikini medicine, and so that's treatments and drugs that were developed for the parts of a woman that can be covered by a bikini, we actually don't have evidence on how female cells or diseases of all the major organs in females, your heart, your kidneys, your lungs, respond to the treatments that we actually have today. So hormones, and I'm not just talking sex hormones, are chemical messengers that spread through the body and tell the organ or tissue what to do at that very time. In this case, when we're talking about the reproductive system, the hypothalamus, which sits in the brain, sets off this process. It stimulates the pituitary to make a hormone called follicle stimulating hormone. And that hormone is sent to the ovaries to help to get the ovaries to create estrogen and progesterone. This, more importantly, for a female to have sufficient levels of estrogen and progesterone in their bloodstream, this process must happen every month of every year for about 39 years of a woman's life, so approximately 510 times. The thing is that we have never been taught is that from puberty onward, estrogen plays an incredibly important part in maintaining a woman's health. In fact, I would say it is essential to a woman's heart and brain health. The issue it applies to women's heart health is that we have completely ignored how any disruption of this feedback loop that I'm showing you right here, that happens every month, that has the potential to influence our heart health. In the past, famine or being malnourished or war times led to the ovaries not producing estrogen, and it signaled to the brain not to send out the hormones that are required for this process. The brain basically was deciding this body is not able to carry a pregnancy, or it's not a good time for this body to be pregnant, and it shuts off the release of the follicle stimulating hormone. And you can see from this feedback loop that if follicle stimulating hormone doesn't happen, then you don't get the levels of estrogen that are required for your heart and brain health. Today, there are many, many added reasons for low estrogen levels in a woman's body. And the reason this matters is that the production or lack of production of the sex hormones drives women's health. Gender, on the other hand, when I'm talking about it in sex and gender science, is a social construct developed by social sciences and often is misunderstood to just mean gender identity, and we label it women or men. There are also many other terms in reference to gender identity, like gender fluid or cisgender or genderqueer, but this is not the only component that makes up the construct that I think of when we're talking about gender. It's linked to power and economics, and it's very distinct from your sex. It has a number of dimensions, 4 of which that have been identified that we explore when we're looking at gender science. So we talked about gender identity. We also talk about gender roles, gender relations, and institutionalized gender. Here's a really practical example of what I'm talking about. Genesis Praxis was a study that I was involved with that included women and men under 55 years of age who were admitted to a hospital across Canada having suffered from a myocardial infarction. And we collected and included 26 psychosocial gendered variables. Higher scores represented behaviors typically ascribed to women. And you can see that the gender distribution revealed that half of the women, the blue line, had a more androgynous or masculine gender score, and 16% of the men, the red dotted line, exhibited a more feminine gender score. And as would be expected, both males and females reported behaviors along the continuum of these gendered variables. The results were just absolutely enlightening to me, at least. On the left, you'll see the percentage of participants who returned with a second heart attack within 1 year, and it was when it was stratified by sex. The percentages were equal when we looked just at males or females. However, looking at the bar charts on the right, you'll note that irrespective of sex, people who scored higher on our gender index, reporting characteristics typically ascribed to women, were 4 times as likely to return with a second heart event within the first year of their myocardial infarction. I might add that one of the variables that contributed the most to the gender index was on a scale of 1 to 10. What's your stress level at home? So I'm sure you're thinking, when do we get to hear about women's heart health? Well, to start with, 2 things collided in my life in 2024. The first important thing that happened to me was that I became absolutely immersed in the literature on reproductive aging. Language matters, and terms like perimenopause and menopause are still very stigmatized in our society. Reproductive aging is a process that begins in a woman in her late 30s and continues until 1 year after her last menstrual cycle. It affects every aspect of a woman's health, and neither women nor their clinicians, including cardiologists, are clear on the associations. The second thing was, as you may have heard, I'm fortunate to be the chairholder of the Caverson Chair in Women's Health Research. And when I first got the chair, every time I mentioned the name of the chair, people thought of old ladies research, because it was the Caverson Chair in mature women's health research. And it's not lost in me that I'm one of those mature ladies. But based on what I was learning and my beginning understandings of reproductive aging and recognizing the incredible gaps that we know, I was able to speak to Dale Sheard, who's the wonderful person who supports the chair, about changing the name of the Caverson Chair in Mature Women's Health to the Caverson Chair in Women's Health Research. So one more building block to understand women's heart health is understanding reproductive aging. So in 2001, the Staging Reproductive Aging Workshop occurred, and they established criteria for the late reproductive stage, which happens before what we label as perimenopause. But it's also part of the menopausal transition. The follow-up Straw 10 conference further subdivided the late reproductive stage into 2 stages. Stage 3A marked by rises and increase in follicle-stimulating hormone and subtle changes that occur that might occur in your cycle but may not. An important aspect of understanding the path of reproductive aging includes recognizing the effect of the potential challenges and stressful events that are also happening at the time of a woman's life. They occur concurrently. So these are the gender factors that are happening, including health concerns, family issues, parents, young children, work-related issues, rebalancing work and personal life, deaths, frustrated goal attainment, financial worries, just to name a few. Women in the late reproductive stage may even go to a clinician saying something like something is wrong. A colleague of mine said that 3 of her friends actually went and got an MRI because they were suffering from what we label as brain fog, which they actually thought was early Alzheimer's. These concerns are now labeled, I am not feeling like myself. But when you go in and you report these symptoms, I'm not feeling like myself, I'm moody all the time, I might have headaches, etc. The clinician will ask any menstrual cycle changes, and the woman says no, and will probably be saying in the back of their head, I'm not in perimenopause yet. But the conclusion becomes that it must be caused by the stress in your life. And they are often sent home saying you need to handle the stress in your life. But these symptoms are actually caused by biological hormone changes that have started in your body. This is called a radar chart. And as you can see from the chart, the phrase not feeling like myself was most strongly associated with anxiety, vigilance, fatigue, brain fog, sexual symptoms, volatile mood symptoms, individual symptoms of low feeling or crying or tearfulness. I have to tell you, I had my own experience with this. When I was around 41, 42, I went into my clinician saying, I think I'm going to kill someone. And I had so many experience of taking someone's head off, and it wasn't me. And I can only explain it as this burning in my gut that I was just angry all the time. And I went into the clinician who said to me, have any changes in your period? And I said, no. And she said, it must be stress at home. Maybe we should try an antidepressant. And no criticism of the clinician. She was really trying to be helpful, but I wasn't depressed. That wasn't the issue. So the importantly to remember about this is the changes in emotional, cognitive, stress tolerance, and energy levels are very unfamiliar and unexpected, and they're not recognized as changes related to reproductive aging, particularly in women in their late 30s. And Kozloff, one of the people who's written about this, concluded that women lacked explanatory models for why the changes were occurring. Also, interestingly, women were really surprised that there were symptoms that occur before changes in your menstrual cycle, traditionally accepted as the harbinger of the menopausal transition. Only 2% reported that they expected changes to begin at 35 to 39 years of age. So back to reproductive aging. The biggest difference is that the late reproductive stage and perimenopause is that women in the late reproductive stage have really regular cycles. They may have small, subtle changes that they might not even have noticed. However, during the late reproductive stage, your estrogen levels are erratic with spikes and declines, and progesterone levels may be lower and also continue to decline. And the progression through these 2 stages is not necessarily linear. If you look at the middle panel, you see that the changes occurring in the late 30s and 40s are due to these fluctuating sex hormone levels. And in the context of women's heart health, the most important of these are the changes in your estrogen level. Estelle Rami, I came across her, was an American endocrinologist, physiologist, and feminist who made significant contributions to the study of hormones and their effects on human health. She is best known for the challenging sexist claims about biological differences between men and women, particularly in response to a 1970 remark by a politician who suggested that women's hormones made them unfit for leadership and disease resistance. The point is, we've known this for a long time, that while estrogen, and I'm talking about endogenous estrogen, so the estrogen that your body makes, dominates and shapes a woman's health, but somehow it's gotten lost in all of our specialized care. The most important point here, as it relates to women's heart health, is that decreases in endogenous estrogen result in changes to your heart and your blood vessels, as well as your brain and your kidney, your lungs, etc. Estrogen is primarily produced in the ovaries, but it also is produced in the adrenal glands and fat tissue. There are over 400 estrogen receptors throughout your body, which is why the effects of high or low estrogens have significant repercussions. Receptors and sites include the brain, the muscles, the gut, the uterus, the ovaries, the breasts, the eyes, the heart, the lung, your blood vessels. Estrogen does many things, but the thing we think about primarily as estrogen is it's a growth promoter. Progesterone, on the other hand, is made in the ovaries while a woman is still ovulating. And after menopause, it's made in the adrenal glands in smaller quantities. But progesterone receptors are found exactly the same place as the estrogen receptors. Estrogen promotes growth and progesterone promotes calm. So while it's long been recognized that women's heart health is altered by menopause, what is not recognized is estrogen affects women's heart health long before menopause. You'll see here on this slide the role of estrogen on the reproductive bone health, but I've highlighted the role of estrogen on the cardiovascular system. And I'm going to be a little detailed here because this is why estrogen is so important. So estrogen is responsible for vasodilation in our vessels. And the way it does is it increases nitric oxide production. Low estrogen means that's not happening. And vasodilation is when your vessels dilate to allow more blood to flow, or it will also affect constriction. So when they need to close off so that you get more blood to your brain and your heart. Estrogen also inhibits pro-inflammatory cytokines. Without estrogen, inflammation is way less control. Inflammation is bad for cardiovascular health. Estrogen modulates the calcium signaling in vascular smooth muscle, which reduces the contraction of those muscles. Estrogen is responsible for this. Estrogen enhances hepatic LDL receptors. LDL is the bad cholesterol. And when you have estrogen, it improves the clearance, and it also boosts HDL, which is the good cholesterol. So that's not happening if your estrogen isn't present. Estrogen upregulates antioxidant enzymes and reduces free radical production. It stimulates angiogenesis, which is the creation of blood vessels, and low estrogen reduces this capacity. It also provides cardiovascular protection overall. It protects against atherosclerosis or blockages by improving your lipid profile, reducing inflammation, and maintaining the inside of your vessels, or the endothelial health. And when estrogen is said to have an excitatory effect on the brain, making you anxious or irritable when there's too much, progesterone is said to be calming. Progesterone influences your mood and emotional well-being through its effect on the brain's neurotransmitters. Overall, maintaining balanced progesterone is important for emotional stability and mental health. Low progesterone, when added to high stress levels, have effects on women's heart health. It also promotes sleeps by acting as a natural sedative in the body. So let's talk about the modern day causes of estrogen-progesterone imbalance in today's world. So the main one of these is stress. It is incredibly important to note that as a woman progresses through reproductive aging, the effects of these hormonal changes, particularly the mood changes, the levels of anxiety, the cognitive changes, are really difficult to differentiate from the concurrent life stressors that as a woman progresses through the stages of caring for children, managing paid and unpaid employment, balancing the life roles. The late reproductive and perimenopausal stage is considered the most stressful time of a woman's life. Thomas et al. Reported that the most commonly reported challenge of midlife women is managing the multiple responsibilities attributed to their roles. And a study from the Seattle Midlife Women's Health Group identified that the participants found themselves searching for balance in the midst of all of these multiple occurring stresses. When asked in the past 15 years, what was the most challenging thing, midlife women report, it was coping with all of these co-occurring stressors. Please note the red flag on this slide because this is the most important thing about stress. The brain prioritizes the production of cortisol during stress. So cortisol is produced in what we all know of as the fight or flight response. Thanks to the hormones in our body, it prepares us to either fight or, in the old days, run from the tiger. Once we were safe, cortisol returned to normal. The issue today is that there are so many tigers coming at us that cortisol never goes back to normal. High cortisol levels associated with chronic stress impact the levels of estrogen and progesterone in your body. Elevated cortisol leads to hormonal imbalances because the brain prioritizes cortisol. It's thinking, you have so much stress, you need to have cortisol, and it will not send out follicle-stimulating hormone. So you are not producing the levels of estrogen and progesterone that you normally produce if you weren't in chronic stress. This results in lower levels of estrogen, progesterone that contribute to symptoms like you may get irregular menstrual cycles, you'll get mood swings and sleep disturbances. Additionally, high cortisol interferes with the normal functioning of the ovaries and adrenal glands, further complicating this hormonal imbalance. In addition to cortisol levels, high stress levels create a cascade of a number of physiological effects of stress that also put women's health at risk. Stress increases systemic inflammation. Stress leads to high levels of pro-inflammatory cytokines. Those are the cytokines are the molecules that are trying to fight off whatever it thinks your body is trying to fight off. Chronic stress alters the white blood cell levels, so it suppresses your immune functions and your ability to fight things off. Chronic stress lowers lymphocyte levels. It increases blood sugar levels due to the action of cortisol and adrenaline. Chronic stress contributes to long-term blood sugar imbalances, which is metabolic syndrome, which also contributes to the cardiovascular disease. Stress-related insulin resistance happens. Stress can alter your lipid metabolism, leading to higher LDL levels and triglycerides. And we already talked about the fact that without estrogen clearing them out, they're already high. The bad cholesterols are bad, and we aren't increasing the good cholesterols. Chronic stress dysregulates your thyroid hormone level, and stress alters all the neurotransmitters that impact mood and stress response. We absolutely underestimate the impact of stress on women's heart health. The estrogen used in birth control pills is a synthetic form of estrogen and often referred to as ethinyl estriadiol. It mimics the effects of the natural estrogen produced by the ovaries, but its chemical structure is actually different, and it affects how it's metabolized in the body. Birth control's job is to fool the brain into not producing the follicle-stimulating hormone, which is follicle-stimulating gets eggs being produced in your ovaries saying we're getting ready to have one of these guys be fertilized. and it produces estrogen at the same time. And the synthetic hormones in the pills work to inhibit the natural hormone signals that stimulates the ovaries to produce estrogen. So when you're on your pill, you can also, even though it may be estrogen, you can also have a low estrogen level. So the suppression of follicle-stimulated hormone is the key mechanism how birth control regulates your menstrual cycle and prevents a pregnancy. IUDs may be drug-eluting IUDs with progesterone. IVF, or in vitro fertilization, causes hormone imbalances due to the introduction of synthetic hormones such as gonadotropins that stimulate the ovaries to produce multiple eggs. This leads to fluctuations in your hormone levels as the body responds to the external hormones differently than it would to natural hormone cycles. Additionally, the rapid development of multiple follicles overwhelms the body's regulatory system, which leads to imbalances in estrogen and progesterone. More importantly, Dr. Natalie Crawford, who's an infertility specialist that I happen to see on YouTube, reports that regardless of the reason the brain shuts off the production of follicle-stimulating hormone and ultimately estrogen, it may take years to reprogram your brain to start the process related to the production of hormone normally again. Excess weight loss, dieting can cause hormone imbalances in women. This disrupts your HPO axis again, and it leads to reduced production of estrogen and progesterone. So low body fat also affects the secretion of leptin, which plays a regulating role in the menstrual cycle. So women experience irregular periods or amenorrhea, which is an absence of menstruation for over 3 months when they lose significant weight. When you're amenorrheic, when you do not have a period, it means that you are not necessarily producing enough of the endogenous estrogen that your body would normally produce. Excessive exercise causes hormone imbalance because it places significant physical stress on the body. This stress leads to elevated levels of cholesterol and stress hormone, which interferes with the production of estrogen and progesterone. I'm starting to sound it's repeating over and over. And finally, obesity in females can cause sex hormone imbalances, primarily due to excess adipose tissues, which also produce estrogen. The increased estrogen leads to imbalances in other hormones and can lead to conditions like increased risk for disorders like polycystic ovarian syndrome. I told you that I did a deep dive into the literature on women in the late reproductive stage, and one review spoke about a Google search done to identify research on what we call post-reproductive women, women in the late menstrual stage, reproductive stage. There were 5 million hits on this Google search. 2.5 million were companies and industries that were trying to sell women the latest products or vitamins or supplements or get them to come to their specialized clinic. The other 2.5 million hits were women trying to talk to other women about what was going on in their lives. 4 studies out of 5 million were done by a group of researchers in Seattle called Women Living Better. And they reported on what we now label as not feeling like myself. It's most strongly related with anxiety, vigilance, fatigue, pain, brain fog, volatile moods, and individual symptoms of feeling low and tearful. The changes in emotional cognitive stress tolerance and energy levels were very unfamiliar to the women. We started to think that given that we have never paid attention to the association of reproductive aging and health, especially in the context of other women's health issues, let's think about it in the context of women's heart health. So I'd like to tell you a story about how this all started to make sense, to me at least. One of my grad students was telling me about a study that she'd come across whereby postmenopausal women underwent an exercise intervention. 2 groups of women, both getting the exercise intervention. One group received estrogen and the other didn't. There were no cardiovascular benefits seen in the women who only exercised. At the same time, an American track and field champion, Tori Bowie, who won the gold, silver, and bronze medals in the 2016 Olympic Games, died of pregnancy complications that may have included eclampsia, according to the autopsy report. Bowie was found dead in her bed May 2nd, when she was approximately 8 months pregnant. We were also hearing stories about Serena Williams and her complications with pregnancy, and Beyonce and Kim Kardashian, just a few of the well-known figures who experienced preeclampsia, which is a life-threatening form of high blood pressure, and it occurs in pregnancy and postpartum. One thing we know about the two groups of women, the menopausal women and athletes, is that they have a common lack of endogenous estrogen. High-level athletes have years where their vessels do not have the benefit of endogenous estrogen because they are amenorrheic. They are not having a period. This actually led to my grad student, Nicole, who brought me the study in the first place, writing up an article on the effects of the sex steroid hormone on cardiovascular physiology in female. And it started to really twig what we were thinking about what was going along with this lack of estrogen. This led to a systematic review on secondary amenorrhea, which is no period, on cardiovascular disease risk in physically active women. So systematic reviews are you look at all the literature you can find and you look at what the results are in common. And this was actually published in the Journal of the American Heart Association. Spoiler alert, physically active women who had secondary amenorrhea had significantly lower estriadol levels and flow-mediated dilation, the dilation of the vessels. They had lower resting heart rates, and they had higher total cholesterol, triglycerides, and high-density lipoproteins and low-density lipoprotein cholesterols. These are high-level physically active women. Those are all things that estrogen is supposed to be taking care of, but they've been amenorrheic, and so their vessels, it's not being taken care of in their blood vessels. Around the same time, I was actively involved in the Canadian Women's Heart Health Alliance, and one of the things that struck me was the number of fit, young women with lived experience, so those are women who have had a heart event, telling me that I was a long-distance runner or I was an athlete. One of the first projects that Dr. Sharon Mulvey and I launched was called the Canadian Women's Heart Health Alliance Atlas. And we put together a collection of 9 chapters published in the Canadian Journal of Cardiology Open. And open journals mean anyone can read it. You don't have to download it or be part of some academic facility. It was accompanied by detailed infographics that reported on the current state of cardiovascular disease in women. The goal of the Atlas was actually to help clinicians and women recognize the unique aspects of women's heart health. And one of the most fulfilling chapters for me was chapter 3 that was written by women with lived experience. And they talked about being stopped at the gate. In other words, not being able to get the cardiovascular care that they needed. In my world, one of the most important documents that was created from the Atlas is this diagram that you see in front of you that includes cardiovascular risk factors associated with every stage of life, starting at puberty right up to the end of life. You can see the traditional risk factors noted at the top and the age in decades along the bottom. The traditional risk factors of smoking, hypertension, diabetes, obesity, hyperlipidemia, or high fats in your blood, dietary patterns or sedentary behavior, they all still hold, but that's not what we were seeing walking in the doors. And so it really struck me that all of these conditions, early period, below 11 years of age, menstrual cycle irregularity, polycystic ovarian, late menarche, contraceptive use, autoimmune rheumatic diseases are either related directly or indirectly to estrogens and progesterones. So a quick Google search also identified other gender-related factors that are also been noted as being associated with risk of heart disease. This one made me laugh because it was just published in 2024. Who's doing more and when? Gender, parenting, and housework trajectories. But what they concluded is that housework increased between age 32 and stabilized at age 43 before declining by age 50. For women and men's laundry, women's kitchen, average to housework, cleaning, grocery shopping, overall housework, and men's house cleaning. When raising children, women contributed more than the men that were raising children. So the interesting thing about this is when I talked to you about that Praxis study earlier and we measured gendered variables, one of the things we measured was hours of housework. And remember I said it wasn't necessarily related to sex, but it is a behavior typically ascribed to women, and more women reported much higher hours of housework. And this was picked up around the world. And there was an NBC station in Tennessee that phoned to talk to me about, their title was "Housework is Bad for Your Heart Health." And the thing that really, it backfired as far as I was concerned, because the thing that the housework was telling me is it's not the housework, it's the juggling all the roles that are involved in keeping that household functioning. The other things that we've identified that have been identified in the literature, I even had one of our master's students work on this, is that intimate partner violence is associated with early cardiovascular disease. And again, women who are living in an intimate partner violence situation are living in high stress and are likely living in chronic stress. And I'm thinking probably estrogen isn't being made in their lives. Childhood adverse events. It's a measure that we have to measure physical, sexual, mental health issues that occurred in your childhood. And those are associated in women with early cardiovascular disease. Gender roles, gender relations, whether you're married or widowed, actually, women who are widowed or single have better outcomes as far as cardiovascular health is concerned compared to the married ones. And gender identity, the stress of trying to present as the way you feel is significant. So this will be my 6th year of being actively involved in Wear Red Canada Day, and it happens on February 13th, and it was initiated to create awareness of women's unique heart health events. We do things across Canada. It's been really fun. But one of the things that I've been thinking about is we're still sort of saying the same things and creating awareness that we've said for the last 5 years. These are the slides that have been created for the community events. And these messages might be familiar to you because they're basically the same message that we've been presenting. So back in 2018, Heart and Stroke released their annual heart report called Misunderstood. And the reports put a spotlight on the issues facing women and cardiovascular disease in Canada. So when it comes to heart disease, women are under-researched, underdiagnosed, undertreated, undersupported, and underaware. Despite women making up over half the population, 2/3 of heart disease clinical research has historically focused on men. And as a result, the diagnosis, the treatment strategies are based on data from middle-aged white males, and they lead to medical decisions for women being using research that doesn't account for how heart disease manifests in men. Importantly, none of the medication treatments were developed in the context of women's reproductive aging stage. Where are you at? What drug or whatever how we're diagnosing your heart disease matter based on what age and stage you're at. And it harkens back to my earlier comment about the diversity among women. Our team now has identified guidelines with treatments that were not tested in females. Females still represent 0 to 35% of all of the randomized controlled trials that are used to determine what treatments are used in cardiovascular care. The other thing is, I'm an epidemiologist, and I can tell you that when someone says they're controlling for sex in an analysis, it's wholly inappropriate. And the reason being is that if you have 80% men, when you control for something in an analysis, say you're controlling for age, you make everyone the same age to see if age has a relationship with the outcome that you're looking at. So when we control for sex in any of these trials, and it's 80% men, we're controlling for 80% maleness. So you're not actually saying anything about sex when you control for sex. Our work in late reproductive and perimenopausal women is identifying that even when there are enough females in the trials, the drugs are to treat men and postmenopausal women's heart disease. And one example I have of that is one of our students was interested in looking at ibuprofen pain medication in IUD insertion. And for some women, it is the most painful experience that they have had. And so what we ended up doing is ibuprofen is one of the drugs of choice for actually menstrual cramps, but also IUD insertion. And so she went back and looked at the monographs of the trials that were used in Canada to say that ibuprofen is a good and safe drug to use. And all she did was she looked at the women that were in those trials. Well, during the time of the trials for ibuprofen, there was a rule on that we didn't include women of reproductive age. And I want to let you know that that's women between 13 and 52 years of age. That's what women of reproductive age are that's the range of that. And the reason was because they were concerned that if the woman became pregnant, that it could alter the fetus in some way or another. But it also means that ibuprofen, the basic drug for women's menstrual cramp, has never actually been tested in women of reproductive age. So what about women in the late reproductive age and perimenopause? Like, what do we know about that? And I'm telling you right now, we know little to nothing about that period of reproductive aging. This is a list of the most common female-specific diseases of the heart. And it tends to appear in, this is a picture of the heart, and the big vessels on the top are the coronary arteries. And those are the vessels that get plugged with plaque in a male heart attack, a typically male heart attack. They get plugged over the years. And what happens is your heart, which is a muscle, gets blocked from the blood is carrying oxygen, and it blocks that oxygen to the heart. And that part where it's blocked, that area dies in your heart. And so that area isn't good for contracting anymore because those cells have died. So in women, the most common type of heart disease that we've identified is in the coronary microvascular. And those are all the little vessels that attach to those main coronary arteries. And this is way more common in females. And it means also that the symptoms that women describe don't fit the classic textbook picture of heart disease, because when one of those big coronary arteries gets blocked, it causes incredible pain, muscle pain, because that muscle, your heart, is not getting oxygen. You feel like an elephant is sitting on your chest, and you actually go into fight or flight. And so you will have what's called a diaphoretic incident. You'll sweat profusely. And those are the symptoms of a male heart attack. But one of the most interesting things about females' anginal pain or heart pain is that it's more likely to happen when the women are resting. It's not exertional pain. So you'll hear on snow days that you have more heart attacks in people because they're out shoveling, and that causes an increased demand on their heart, and they end up having a blockage, and they end up having a heart attack. But women do not necessarily talk about exertional pain. They'll be sleeping and wake up in the middle of the night, and they have anginal pain. And the reason this matters is because every clinician is taught when a man or a woman walks in the door and say, I have incredible chest pain, they're taught to ask the question, were you doing something when this came on? Because we know that exertion actually precipitates typical coronary artery heart attack. The other thing is the plaques or the blockages in female are more likely to erode, or they partially rupture. So they may rupture and not even be seen when you go for a cardiac cath looking for blockages. Females are also more likely to have a coronary spasm, vasospasm, and that's just the coronary arteries and the vessels underneath go into spasm, which means they're shutting off, and it reduces their opening and closing, like if you think of a spasm, and they're decreasing the oxygen to the heart, and the heart says, I'm not getting the oxygen I need. This may have something to do with your levels of the sex hormones, actually, because we talked about all the things that keep that vessel pliable and make all of our arteries and vessels remain effective. 90% of a thing called SCAD, which is spontaneous coronary artery dissection, are in women. And Jen Gunther, in her book Blood, writes that pregnancy is the metabolic equivalent of the Tour de France. It demands so much on a woman's body. And we have often called it the first stress test that a woman has, because your blood volume doubles and all of the issues are related with that. And we started thinking, what if a woman, like an athlete, experienced amenorrhea, so no period, for 2 years of their life as they're training for the Olympics? And like the athletes I mentioned, that acts because they don't have the protection of estrogen, they get vascular damage or damage inside their blood vessels. And then they get pregnant and they're challenged to deliver that baby. And remember, the metabolic equivalent, it's asking your body to do the Tour de France, to have and deliver a baby. That's often when SCAD shows up. And SCAD is those coronary arteries, those big arteries on this picture here, they just split. And that to me is saying something has happened to that vessel. It's not operating the way it's supposed to operate. ANOCA and MINOCA are ischemia with no coronary artery obstructions. And MINOCA is when you have a heart attack and you don't have any coronary artery obstructions. And this is a female predominant condition. And Dr. Tara Sedlak's group in Vancouver published that 2/3 of the angiograms or cardiac cath for women with suspected ischemia reveal ANOCA. And predominantly underlying ANOCA and MINOCA are coronary microvascular dysfunction and coronary vasospasm. And I think those might be related to your levels of estrogen in your body, or if you've had some malfunction or dysfunction prior to getting pregnant. The signs and symptoms also we talk about frequently, but they're also, women will experience some kind of chest discomfort rather than crushing pain. They do have shortness of breath. They do have fatigue, indigestion, nausea. But the important thing is women under 55 years do not have the common risk factors that present in their male counterparts. They're fit, they're non-smokers, they're active women. And microvascular dysfunction and so coronary vasospasm, they're not easy to diagnose whatsoever. We don't have a standard test for diagnosing them. So women and their healthcare providers can sometimes be slow to recognize the signs of a heart event because we just haven't even thought that it could be your heart, especially when you're seeing the women that experience heart events between 35 and 45. It's not who we would think would have a heart event. And they're missed and overlooked and misdiagnosed. In fact, heart attacks are still missed in 78% of women. And it's especially common misdiagnosis in younger women because they don't experience the common symptoms that we think of. Physicians focus on other possible causes without first conducting the necessary tests to rule out a heart issue. Ironically, clinicians will see a woman and they think they're probably in their late reproductive stage or perimenopausal. When they look at them, they don't have the symptoms, and they're talking about the stress level of their life, which may be causing the symptoms that are directly related to their heart health. The other thing is women continue to delay seeking help due to fear, embarrassment, living alone, not wanting to bother anyone, or misinterpreting the symptoms. So our own research has identified that women describe chest pain differently as pressure or tightness. And this book was from the book club I'm in, and it's historical fiction around the development of the Oxford English Dictionary. And the historical aspect of this book is that women's words were not included in the development of the Oxford English Dictionary. If a word was defined as something that women use, then it wasn't included in the dictionary. And that was just fascinating to me. But I had taken my mom into the ER a few years ago, and I was talking to the ER nurse about women's heart health. And she ended up telling me that if a woman doesn't say the word pain, they don't get put into the chest pain protocol. And so they will not be investigated for chest pain related to their heart events. Importantly, women's symptoms occur more often when they're resting, if not when they're asleep. And women tend to show up in the ER after the event has already occurred, and their symptoms are not those usually found as a cardiac event. It is not uncommon for women to go to bed thinking they have the GI or a flu of some kind to find out that they've had a heart event. Over the past decade, we've seen mounting evidence of sex disparity in cardiovascular disease. And heart disease in women is underestimated, with notable differences of how it's identified and treated. First, there are differences in the signs and symptoms. Second, there's a lack of awareness. And lastly, there's knowledge gaps, huge knowledge gaps that exist. The other thing that we are not doing is ever looking at heart disease or lung disease or kidney disease in relation to the post-reproductive aging. So despite years of information campaigns, women and clinicians still remain underaware of the significant threats that heart disease poses to their health. And about 60% of women who were surveyed didn't recognize that they were at high risk for heart disease. And it's not the women's fault, because we're identifying things that women didn't know put them at high risk for disease. One of the things that we absolutely know now is pregnancy complications like high blood pressure in pregnancy, gestational diabetes, and preeclampsia, which is a type of high blood pressure again, are associated with higher risk of showing up with early heart disease. And the reason I'm telling women that is not to scare them at all. It's to say that things can be done to prevent the development of that heart disease. But women need to know, and women need to discuss this with their clinician, saying, am I at higher risk? So here are some take-home messages. I know that I have presented a lot tonight, but to me, the more women understand and are aware of what's going on in their bodies, the more we can start to make differences in women's heart health. We need to rethink what is normal for women and women's heart health. Early periods, heavy bleeding as a youth, erratic cycles, amenorrhea are not normal. Honestly, we still are telling women, don't worry about it, your period will come back. We need to pay attention to all of those. Vascular symptoms, and this one, it blew me away. So hot flashes, or flushes, they're called in the UK, or night sweats are actually not normal. And there's a thickness and all reported that women who present with overt perimenopausal vascular symptoms, so hot flashes, night sweats, and or hot flushes, already have indices of subclinical cardiovascular disease, including poor endothelial function. We talked about that estrogen keeps your endothelium working well. Poor flow-mediated dilation. Remember, estrogen helps you with dilation. Greater aortic calcification, and intima media thickness. So, you know, so often we've had the discussion amongst all of our friends about, oh, how lucky I was that I never experienced hot flashes, and other colleagues of mine will have had them so bad that they have to leave wherever they're at. They're soaked. They're not sleeping through the night because they're so soaked with the night sweats. But we're not saying what's different about those two people. And maybe it has to do with the estrogen levels in my life, or the biology. I didn't have complications of pregnancy. I had a normal period. I was on the pill for many, many years, and that can affect your estrogen level. And I just think women need to be aware of that. The other thing is high chronic stress levels are not normal. And telling someone, as a clinician, telling someone, go home and get your stress under control, is not a reasonable solution. Not sleeping, even in perimenopause, is not normal. Lack of sleep has been strongly associated with increased risk of cardiovascular disease, and it contributes to high blood pressure, inflammation, metabolic disturbances, all that negatively impact your heart health. The questions that you need to ask yourself and pay attention to and talk to your clinician about is, what is your hormonal status or reproductive history? On a scale of 1 to 10, what is your stress level? Remember that cortisol production is prioritized over estrogen. You lose the benefits of estrogen if you're chronically stressed. And one of the things that came out of one of the presentations I did this morning actually was that should we be measuring estrogen and progesterone levels? And I'm saying, no, let's measure cortisol levels. The issue with measuring estrogen and progesterone is it's going to be different for every woman that you measure. And we don't know what their normal is like, what the woman that's sitting in front of you is like. And you'd need years of data to say, for you, this isn't a good estrogen level. We don't have that time or the ability to do that. We can order a cortisol level and determine if you are stressed enough that your cortisol is chronically high. And if that's the case, you do know that it's affecting your estrogen level. And so one of the things that we're doing in our studies that we're doing right now is we're trying all sorts of different measures to decrease stress level. And we have a study right now that we're doing yoga for stress. And we're planning one yoga for sleep. And we were talking about music therapy for stress. So different ways that a woman can bring down their stress. And I have to say that this is really, I really related to this because I remember people saying you've got to offload some of the stuff you're doing to your husband. And I didn't want to offload the healthcare, and I wanted to be at the parent-teacher interview. So it's really easy to say you need to get rid of things, but I wasn't prepared to get rid of them at that time. The other thing is, what reproductive aging stage are you in? Remember, women who present with overt menopausal symptoms, those hot flashes and night sweats, already have some form of subclinical cardiovascular disease. The good news is we are starting a study where we're measuring what's called arterial stiffness, which is all these measures that we've been talking about. The issue with measuring arterial stiffness is it still takes about an hour on every woman that we are doing it on, but we're trying to get data to identify women there's a range of arterial stiffness measure. And if you're a 42-year-old woman and you have a really high arterial stiffness, then that's not good. But the good news is there are studies out there that have interventions that improve your arterial stiffness. So I just wanted to talk about the Kaversen Chair in Women's Health Research and how you can help us to get all this information and data that we need to get to start making changes in people's lives. So we have a survey of women, post-reproductive women and post-reproductive aging. It's open to anybody. You don't have to have a heart condition or have any symptoms. We just are trying to get the data on women so we can start looking at the data and saying, oh yeah, there is an association with this, with things that have been identified in the literature, and how can we try and intervene? We collect things, and we believe by asking about these sex and gender factors, we better understand and improve not only women's heart health, but understand women's health in general. This is a QR code that can be used to connect to the survey, and we would just love anyone and everyone 35 years of age and older to complete the survey for us. This is being recorded, and you'll be able to be sent this later as well. We also, at the end of the survey, which takes about 15 minutes, we ask women if they'd like to be involved in future research. And in particular, we're setting up studies to use evidence-based therapies to try and address these issues. And we also are launching our study of advancing women's cardiovascular care, investigating arterial stiffness with a nurse practitioner-led cardiac assessment. And this is through the Lois Hole Hospital, in conjunction with the Lois Hole Hospital for Women and the CK Huey. And this is on women who have a condition called non-obstructive coronary artery disease, but that's where we start and we go from there. The other thing is watch for a post-reproductive aging clinic. we're actually actively working to launch a post-reproductive aging clinic because there is no care for women in this stage of life. And with that, I want to thank you for all your intention and indulging me over this time reflecting on women's heart health. Thank you too to WICRI and the Alberta Women's Health Foundation, and especially the Royal Alec Hospital Foundation, CK Huey Heart Center, who have provided me the support and consistently include me in all things women's health through panels and presentations and even things like Twitter chat. And I look forward to, I know I've gone over time as usual, but I look forward to any questions.
The overtime is so welcome, Colleen. Thank you so much for so much good information. There's a few of us members of the or supporters of the Lois Hole Hospital Women's Society all together in a room here, and there were lots of moments of, oh, I didn't know that, and giggling out loud. And so if any of you on the call like to grab some girlfriends for another one of these, I can tell you it's a good time. We had a lot of fun in this room. And thank you so much for so much great information. There are a lot of questions. There's a few kind of themes, and one of them that I want to dig into right away, because I think it came up a few times, was about hormone therapy as we advance in our lifespan, specifically risk benefit of hormone therapy over the age of, one person said 69, one person said 72. And the questions were about persistent vasomotor symptoms, so hot flashes, night sweats at the age of 72. Is that indicative of a lack of estrogen? And then other questions about hormone therapy at age 69. And is there like a bigger risk of blood clots? And does vaginal estrogen on its own carry risk as far as blood clots? And so I wonder if you could just riff on hormone therapy as we advance in our lifespan for us.
Yeah, so hormone therapy, and I want to be clear that what I'm talking about tonight is not that everyone should get on estrogen and progesterone. It's just figuring out what your estrogen level is by symptoms. And I actually use ChatGPT a ton, and I love it. I actually love it. And I think if you use the eyes of, is this a true reference or not? And really, you can learn a lot with it. And I said, what are the natural methods of improving your estrogen level, just as relates to the talk tonight? And they had really great, well, that Brianne, but different foods, physical activities, you can improve your own estrogen levels. So having said that, the issue with hormone replacement therapy, and it's not called that anymore, it's just called hormone therapy, because you aren't replacing it, because typically in menopause you don't have it anyway. So the studies that came out just blew the lid off, and they were inappropriate. They weren't done well studies, or studies that were done well. But what they indicated was there was a risk for breast cancer and actually for cardiovascular disease on the big women's health study. The issue with that study is that the average age was 63 years of age. And when they went back and they stratified it by 55 years and younger and 55 years and old, or 56 years and older, hormone therapy was actually protective for women under the age of 55, protected you against cardiovascular disease. And it's called the timing hypothesis. And the timing hypothesis is you should not start hormone therapy if you are over 10 years from menopause. And the average age of menopause is 51. And so I'm saying like 61 and over, if you've been in menopause 10 years, all those receptors I talked about, those 700 receptors, they've actually shut down. So if you bombard your body with estrogens, it could be problems. And so I kind of envision a time where we're trying to, there may be some women under 55 that, to prevent that crazy erratic thing that's happening, they're put on biosynthetic or estrogens and progesterones, which actually mimic your body and can be given in dosages that are appropriate. Now, one thing that you mentioned about, I don't I can't say offhand about the vaginal cream. One thing that occurred to me again, and maybe this is too much information, but I went to the physician and he said on the exam, you look like you could use some estrogen down here. And we have tablets that you can put in your vagina and try it for 2 weeks. The good thing is it's local and it stays in the area. Well, within 2 days, I thought I felt like I was 13 again. I was moody and I had cramps, and I said, okay, this estrogen is going systemic. There is no way. And the other thing that really twigged me was, how can you give the same dosage to me at my height and my weight as you would give to the woman that comes in next, who's a different age and a different height and a different weight? How do you know that that's the dosage that you should be getting? So I'm not happy about those things because we haven't figured out what dosage works for what woman. And so I do think that the one thing that has been identified is that hormone therapy absolutely works for symptoms that the women are talking about, these vascular symptoms. And when it's debilitating, you stay on the hormone therapy. And one of the things I was reading about was, do we keep taking estrogen levels? No. The common word out there, and Jen Gunther talks about that, is that you stay, if the hormone therapy gets rid of the symptoms, stay on the hormone therapy because it's stopping the symptoms. There are other things that you can do that can improve your vascular health at the same time, right? And lifestyle things that you can do that will improve your vascular health. So I mean, it's not cut and dry. It isn't that it works or it doesn't work, or you should be on it or you shouldn't. I do think the rule of, if you're 10 years past menopause, you're not going to be starting on hormone therapy.
Awesome. Thank you. I think that answered a whole bunch of the questions that came up. So thank you so much for that information. And another question that's in a similar vein was about continuous oral contraceptive use or IUD use where there is amenorrhea. So if we're like using a oral contraceptive continuously to prevent a menstrual cycle, or somebody has a progestin-only IUD and they're not having a menstrual cycle with that device in place, does that type of amenorrhea or lacking of a menstrual cycle correlate with cardiovascular disease risk?
I think it can, to be honest. And that's what, like I was saying, no one ever told that to me. These are all things that, best thing for you, you won't get pregnant, get on the pill. Yes. Okay. Sounds good. Right. And I think that's good. I think we have to be able to control our reproductive system, but you can assume that your estrogen level is not going to be at the level it's supposed to be for the cardiovascular events. And so then you do turn to those other natural ways of improving your own endogenous estrogen that's being produced.
Yeah, awesome. And so they can be supportive for some goals at different parts of our lifespan. And we also have to take into context future disease risk when we're using those items.
Yeah. And the IUD has progesterone in it.
Yeah.
And so you may still well be drug-eluting IUD. And I'm not obstetrics and gynecology. Like, honestly, when I said I went back to the books, I went back to the books. I was trying to say, like, I know I learned this at one time, but you may still be producing estrogens, with an IUD that has progesterone, right? And so, that to me is a good solution for birth control.
Doesn't always prevent ovulation.
Yeah.
Okay. And then there was a really funny moment in this room when you mentioned about widows and cardiovascular disease risk.
Yeah.
And we all kind of giggled, but then there was a clarifying question that came up. Can you clarify, do widows fare better as far as cardiovascular disease risk than married or
her? Yeah. So this was in our big approach registry, and we were looking at social support, and part of it was, are you married? And the other question we asked is, do you have someone to take you to appointments, etc. And so it wasn't necessarily that you were widowed or alone. In fact, the men did better if they were married. The women did better, regardless of whether they were married, if they had a friend or a daughter or someone for
Mm.
emotional support. So marriage wasn't the social support for women and their cardiovascular outcomes as it was for men. And that really makes sense to me. And you know, part of the thing we've been saying as far as heart health and awareness, and I learned this myself recently. We've been saying, you know, take your posse or take your friend with you if you think it's your heart, because your friend can play the bad cop and your friend is going to be there to support you. And so when you feel uncomfortable saying, I don't think you've got it right, like I think you're wrong, doctor, no one's going to say that, right? And especially in the emergency room. But your friend can say, that doesn't make sense to me, can you try that again, because she's definitely saying it's her heart. So that's the sort of social support you need. You need, even as far as getting to the hospital, we're now saying that I have, my best friend's name is Colleen as well. And so we have this deal that I'm going to call her and say something's wrong. And she said, I'll call 911, because there's no chance I'm going to call 911. There just isn't. I'd be embarrassed. I'd be thinking this is nothing. And I'm in the business, right? So I know how hard it is. So it's for women, we start using strategies that work for you to get your health in order.
And I think what you said about community and social support is also so valuable. And that's why evenings like this are so important, right? Like not only having that individual to bring with you to the hospital, but also, or to call 911 for you, but also potentially having like these groups of women where we can remind each other of so much of the information that you presented, and keep each other accountable to nutrition and lifestyle and all of those good things, but also managing our symptoms. Like when you were talking about the coronary microvascular dysfunction and being more common in women, there was a question that came up about troponin levels. And do you know if troponin levels rise in a CMD or a coronary vasospasm? So troponin is like a lab test that's done to rule in or rule out a heart attack.
Yeah, and they don't go up.
Right.
And so you can have a vasospasm and blood is cut off from your heart, but it won't necessarily, you know, troponins are because of damage to the heart, right? And so the troponins are released when you have heart damage. And
Right.
so you have this spastic moment where blood is cut off to your heart and you go, oh my God, you know, what happened? And then it relaxes and you're saying, what was that? And you go to a physician and describe it and they say, oh, panic attack, right? I'm looking at you and you look like you're healthy and you're not overweight and you're telling me you're not a smoker or drinking. Panic attack. And so it's sort of saying, yeah, I don't think it's a panic attack, you know, like, yeah.
Yeah. Interesting. And then there's so many more questions. I just want to ask one more before we close, because I think it speaks to sort of the state of the union with respect to rates of heart disease. And so it's a clarifying question around, did you say that the rate of heart disease in women is going up or is it going down? And is there a possibility that that's related to, like, are we doing a better job of recognizing heart disease in women as a potential reason for the rates going up?
I never thought of it that way. That we're picking it up now instead of, yeah. The rates are definitely going up. The rates are definitely going up. I don't think we're picking it up. I think for sure we've got a handle on, you know, the postmenopausal, and that's a no-brainer to me too, because the women without estrogen are starting to look more like the men, right? And so they're saying, well, women present with coronary artery disease, you know, 10 years after men. Well, that's because they've been in menopause for 10 years, and that's what's going on. I don't think we're picking up. And the women in the Canadian Women's Heart Health Alliance will tell you they're going to the emergency 10 and 12 times. And, you know, that study that we've used it between us, you know, we looked at, there are 300 women a year in Alberta that go to an emergency department, are discharged home, and come back within 30 days having had a heart attack. And some of those women, one woman went 15 times in that 30 days saying something is wrong with my heart. And it wasn't until she had a heart attack. And one of our wonderful women with lived experience said she actually, every time she'd go and she'd say, you need to do an ECG, and they'd say, no, because we don't know what your normal ECG is like. So these could be just aberrant things that are happening in your heart anyways. So she went and pretended, she went to the emergency and pretended she was having chest pain. So they do an ECG, so they'd have a normal one. So the next time she had one of these events, they would be able to compare to what her normal is. Yeah, like, wow. So I think we're figuring out ways, as women, we're figuring out ways around the system, but I think it's related to reproductive aging. And I think because we don't know what's going on there, right? And when you see all the things that estrogen does for our vessels, and we do all sorts of things that we aren't paying attention, that you could have consequences to that.
Right.
Right?
Yeah. And so continuing to advocate and for ourselves. And there's so many great, if I hope everybody here has been able to see what's come through in the chat and in the Q&A, because there's points we haven't been able to cover that have shared that lived experience of going in with different complaints, different concerns, and being diagnosed with different conditions, misdiagnosis, etc. And so I think when you hear that from other people, it also strengthens your resolve to say, okay, something's not right. I love that, not feeling like myself, but also like we need to do some investigations before we just chalk this up to anxiety or anything else. So
yeah, and honestly, I really like that idea of just getting cortisols on everyone that comes in. Like, it'll tell you if they're stressed, and then we move from there.
Right. And I know we're out of time, but there's one question and I get to ask it because she's right here. What's the question?
No, I was question. So if you think you're having a heart event and you go to the hospital, what test do you ask them to do? Just like, do you know what I mean? Like, I need you to do this test. Like, what kind of thing can we ask for so that we can figure out if we're actually having a heart event? Do you know what I mean?
Yeah. And it's such a good question. I have to tell you that I had one of these this January where I had such significant pain that my student said, I'm calling 911, because I was saying, no, I'm embarrassed, etc. All the stuff I tell people not to do is just classic. But one thing that really struck me in that is when I was going in the ambulance, and it was like someone was pushing a poker through my chest, and I decided I would close my eyes to try and help breathe through it. And they're saying, what is the level of pain? I said, it's a 10, it's a 12 on 10, but I had my eyes closed. And so the reason I'm telling you that is because I wasn't having anxious behavior. I had my eyes closed and I was trying to breathe through this pain till they got me to the emergency. And the paramedic said, I've got something for your pain. And I said, what is it? And he said, just lift up your tongue. And he gave me an Ativan, which is for anxiety. And I'm thinking, well, are you kidding me? Like, already it's being denied that I'm having something going on with my heart in this. And then he gave me a second one. And then we went in and my troponin, it went up 30, which is not something that you're going to worry about. And then they did a echo. And at the end of the day, I'd had a really stressful event in the morning, and it really tipped me over the edge. And I think that's what it was. And I don't know if it's coronary microvascular disease. At the end of the day, they did go in and do a cath, and they found a blockage, but it was calcified, which means it's really old. And so that wasn't the reason for this heart issue I had. But now they're treating me like I had angina, is what they said. I had an anginal event. And so I'm put on all these drugs, and because they put a stent in, anyways, the bottom line, we haven't discovered what it was, right? Like, I know what it was.
Yeah.
And so I did take the tests, but those tests are not identifying what's going on in women. So we just have to continue working on it.
Yeah. We just have to continue the research, and we have to continue to advocate, and we'll continue to get that information. And you and your team are doing amazing work creating that information that we know physicians will one day have access to. So Thank
Yeah.
you so much for that. And thank you for your for this discussion and for the information that you presented. I also want to thank everyone who attended for being here tonight. If you would like to continue to support the Women's Society, we'd be thrilled for folks on the call to join as a monthly donor. Your donations do support research like Colleen's and many other initiatives at the Lewis Hole Hospital for Women. And we also want to give a quick update that we have a really exciting yoga event coming up for supporters in March, at the end of March, March 30th. If you are a supporter and you want to save the date, please do. And if you're not a supporter, but you're like, hey, doing yoga with people who are valuing and supporting women's health sounds really fun, please become a supporter. We'd love to have you there. I'm going to pass it over to Stephanie. Thank you so much, Colleen. I always learn so much from you, and I'm so grateful. And Stephanie will close us out for the evening.
For sure. Thank you, Brianna. So it does, in light of heart pain, it does break my heart to end it here. This is such great questions and discussion. Thank you so much, Dr. Norris, for your time. I do want to thank everyone for attending and remind you to keep an eye out for the survey. You can complete it to enter a draw for a $25 gift card, courtesy of Alberta Blue Cross. In addition to our heartfelt thank you to our presenting sponsor, I also want to remind everyone that if you have already purchased Luminaries luncheon tickets since the beginning of this podcast, we really appreciate that. And if you haven't had a chance to yet, you can take a moment now to scan the QR code. It's not too late to get your ticket and join us in this cause, because we can see that there is a lot of you that feel very passionately and strongly about women's health and women's health research, and especially advocacy and raising awareness. And this is a great opportunity to join like-minded individuals in a space where we can hear more from Dr. Norris, and to be part of these conversations and invite others in our communities to be part of them as well. Um, in conclusion, again, thank you everyone for joining us, and we look forward to seeing you all in our next session. We hope you have a wonderful evening. And thank you again for all of our supporters of the Lewis Hole Women's Hospital Society.